Hello everyone, presenting to you our video titled Lost in the Sands of Time, an unexpected intraoperative surprise during vitrectomy following refractive surgery. We do not have any financial interest. A 52-year-old gentleman presented to us with decreased vision in the right eye. He gave past history of 2 refractive surgeries in the right eye many years ago. He also gave history of cataract surgery in both eyes 13 years back. Unfortunately, the patient did not have any surgical records available with him. On examination, the right eye showed radial corneal scars suggestive of past radial keratotomy. The eye was aphakic with remnants of lens capsule noted. The fundus was myopic, however, there were no peripheral retinal degenerations. Also, there was no evidence of any dislocated lens in the vitreous cavity. The left eye showed clear cornea with good pseudophakia and a myopic fundus just like in the right eye with no evidence of any peripheral treatable lesions. Since the patient was particularly saying that a lens was placed, we planned for a pars plana vitrectomy to look for any dislocated lens in the vitreous cavity. Also considering doubtful capsular integrity, we planned for a scleral fixation intraocular lens implantation. So this is how the surgery went. Superior conjunctival peritomy was done and a partial thickness sclerocorneal tunnel was fashioned without entering the AC. 3 standard 23 gauge pars plana ports were made. Infusion cannula was checked and started. Anterior vitrectomy was done. Core vitrectomy was done, and as we continued the posterior vitrectomy, all the while watching out for any intraocular lens in the vitreous cavity. There it is. We injected perfluorooctane to protect the macula and to help in levitation of the lens. What we see is that it does not look like a normal intraocular lens looking at the design. Maybe an iris claw lens? Let's find out. An intraocular forceps was used to grasp the lens. It kept escaping the grip, but the endo-illuminator probe helped in directing the lens and getting it towards the forceps. There we go. The lens was held with the intraocular forceps and brought up into the AC using the shake hand technique. A dialer was used to dial the lens into the AC. The previously made tunnel was opened up and the lens was explanted. There it is. It is an implantable collamer lens or ICL and not a regular intraocular lens. The PFCL was aspirated. So let's move on to the second part of the surgery. 2 markings were made 180 degrees apart on the cornea. (10-0) polypropylene suture was passed through the sclera. The suture was docked onto a 26 gauge needle to bring out through the tunnel. The suture was then passed through the eyelet of the intraocular lens and taken back through the tunnel and out through the sclera. The same procedure was repeated on the other side as well, and the sutured scleral fixated intraocular lens was implanted. Tunnel was closed with 10-0 monofilament nylon and conjunctiva was sutured with 7-0 vicryl. The edges of the tunnel were hydrated and conjunctiva was cauterized. Concluding, every vitrectomy surgery is a surprise, more so in cases where reliable history and previous surgical records are unavailable. In our patient who was already operated for cataract, how an implantable Collamer lens dropped into the vitreous cavity still remains a mystery. However, the surgeon should be prepared to handle such unanticipated instances. Thank you for your patience.